two. I mean, in fourth grade, I got to figure out how to, patch my because I did work at the college for a couple hours. That was okay. So extraordinary to learn all these people. They were like, here's a way.
And I thought that what's on the test, you should narrow it down to studies. Like just make a list like the.
It was like 45 pounds. When I was like, I was like 105 pounds. 5 years old.
Yeah, I was like, I mean, but I know.
All right.
I literally have.
We're good.
Yeah, we lost one person. Been the same two guys. Like I said, we could sixth grade. I could still wear shoes in fifth grade now. Actually, my first time on email, like 2 days later. After that, God was like, "You're one go." And then I went to
So, Sydney, what would you ask a patient when you're doing a lower extremity duplex exam? What are some of the questions you might ask them?
Well, I might ask like why they're having the study done, what their symptoms are, which leg hurts, how long it's hurt.
Good, yeah, definitely. You want to know which leg it hurts, where in the leg it hurts. So that's part of your obtaining your patient history. For legs, ask them, how long have you had the pain, how long have you had the swelling? If you wanted, maybe you can ask a little bit if you have any sort of clotting disorders or anything going on with that. Any recent plane travel or long trips or car rides that you've been on. Any reason for like immobility. Physical exam, you're gonna take a quick look at the patient's legs, see if they really truly do look swollen. See if you notice any discoloration to them. In terms of the room, again, nice warm room. We like to have the patients in a reverse Trendelenburg position. So the legs a little bit lower than the heart. This will help to distend the vessels a little bit. The hip will be externally rotated out, the knee slightly flexed. So we kind of call it a frog leg position. That will open up your window to be able to visualize the vessels. In terms of transducers, it's our go-to, our 5 to 7.5 linear megahertz transducer. If we're looking at some of the superficial veins like GSV or small saphenous, we might switch to a higher frequency. If the patient is a larger patient, if they're obese or if they have just thick legs, we might switch to the curve probe. So don't be afraid to go to that curve probe. That resolution is not going to be quite as clear, but you'll definitely be able to image the vessels a lot easier than trying to struggle with that linear probe. We're going to demonstrate compressibility throughout all the segments of the vessels that we're imaging. And then importantly, we're going to look for that phasic flow, that phasicity, those respiratory variations. And then we're also going to practice demonstrating augmentation as well. In terms of protocol, excuse me. Some labs will actually have you start at the external iliac. Some labs might, just have you start at the common femoral vein. In terms of common femoral vein, I collection coffee cups there. It's typically 2 images for that common femoral vein. You'll have just common femoral vein, common femoral artery, and then you'll either angle superior or inferior to try and get that junction where the great saphenous connects in. So this CFV GSV junction is also referred to as the SFJ. So SFJ, SFJ is that saphenofemoral junction. Saphenofemoral junction. So you hear a doctor or someone tell you like get an image of SFJ, that's that connection where the GSV meets the common femoral vein, saphenofemoral junction, SFJ. We're going to continue down the leg through the thigh, compressing the femoral vein. You'll also, a lot of labs will have you get one image of the deep femoral vein right at that bifurcation or split of the common femoral vein. So you'll have your femoral vein, your deep femoral vein deeper. You might have to do a split screen compression at that level, or just a Doppler image showing color at both of those. After following the femoral vein down the thigh, you'll then move to popliteal, and then image the calf vessels. Most slides will just have you do PTV and peroneals. Anterior tibial veins, again, that's something that's almost never imaged in terms of lower extremity duplex exam or venous duplex exam. So in terms of our capabilities, main thing is we're looking for a thrombus, ruling out the presence or absence of DVT. So you guys can differentiate between acute and chronic thrombuses. It could be used to evaluate if it's a non-occlusive thrombus, so if there is still some blood flow getting through that vessel, we can visualize those non-acute thrombuses. Again, we can distinguish between those terms, extrinsic compression versus intrinsic obstruction. So again, we can tell if it's something just from the outside that's compressing that vessel versus an actual blood clot within that vessel. We can also document non-vascular soft tissue masses. With lower extremity duplexes, sometimes we do what's called vein mappings. So in this case, we're looking at the superficial veins. So this is going to be one of our next comps after this lower extremity duplex. We're going to look at the superficial veins, get measurements of the diameter of those vessels for potential use for either bypass grafts, arterial bypass grafts, or fistulas. And then we can also, our duplex exam can also reveal the presence of any collateral channels or recanalized channels. In terms of limitations, a lot of it has to do with, patient body habitus, patient size, how muscular they are. You'll find that patients who are very, very muscular, they're actually probably one of the more challenging people to do lower extremity duplexes on. If you have to assess those iliac vessels or IVC, you might not be able to visualize the iliacs, due to overlying bowel gas. They might just be difficult to visualize. The vessels in the calf tend to be very, very small. So sometimes particularly if they have calf swelling, it might be very challenging to visualize those posterior tibial and peroneal veins. Also trying to get the popliteal, if a patient's not able to bend their knee and you're able to get behind the knee, it might be a little challenging to image the popliteal as well. Particularly patients that are in contracted positions. This is just a little diagram showing now your lower extremity vessels, beginning with the common femoral vein. So we can see again, GSV connects to that common femoral vein at that saphenofemoral junction. We can see there's split, the bifurcation into the deep femoral and femoral veins. We follow that femoral vein down the thigh. Once we get behind the knee, that femoral vein becomes the popliteal vein. And then behind the knee, we then have branches going into our calf vein. So the popliteal splits into that anterior tibial. And then we have that tibial peroneal trunk, same as the artery. And then that tibial peroneal trunk gives rise to your posterior tibial and peroneal veins. So just like the arteries, most lateral anterior tibial veins, most medial are going to be your posterior tibial veins. Peroneal veins are situated in between the two. The only one that's not really listed on here that is of importance is the gastrocnemius vein. So that comes off right around that same area as that small saphenous and connects into the popliteal vein as well. And it's a small little vein that runs through the actual gastrocnemius muscle. And it's considered a deep vein as well because there is an associated artery with it. So when we get in the lab, I'll show you guys where to find the gastrocs as part of one of the images that you guys are going to have to get. So this is just showing, again, patient in reverse Struve-Dellenberg. So try and lower the legs a little bit. Particularly when we get into doing reflux studies, sitting or standing. When we're doing the reflux studies, will help to dilate and open up those vessels. So iliac veins. So in terms of the iliac veins, if we wanted to image common iliac veins, we'd have to go all the way up in the lower pelvis to try and image that. And then we can potentially see the branching into external and internal iliac. If we come high up in the groin, almost into the lower pelvis, you can see the external iliac. So external iliacs, like I said, you know you're in the external iliac when you see it coming from the top corner of the screen and kind of diving down like that. And then the common femoral kind of flattens out. So if we were to extend this out, common femoral kind of, it curves a little bit and then flattens out, and your common femoral will be in that general area. So there really isn't, in terms of ultrasound, you don't really see that inguinal ligament or that demarcation zone between, you know, external iliac and common femoral. So it's essentially just, you know, a continuation of that vessel. So if this was like the vessel and you have this on your screen, I would kind of be able to tell if you were actually an external iliac by seeing it kind of diving deep down like that. So coming from that top corner, just diving down, this would be external iliac. And when the vessel kind of flattens out a little bit, you know, you're more in the common femoral vein. So that's kind of what it looks like when you're on your image. So, you know, somewhere in here will be that inguinal ligament, you know, that we don't actually see on ultrasound, but so acute ultrasound and external iliac. So if you guys do happen to be doing a lower extremity DVT study and their protocol starts with the common femoral vein and the common femoral vein is positive for DVT, try and come up a little bit higher to see if you can visualize the external iliac, to see if you can, you know, get a nice split screen compression picture and then a nice 2D picture to try and image the vessel, the external iliac, to see if that's thrombosed as well. See how far up, you know, you're able to image that clot. You don't necessarily have to go looking, you know, all the way to the IVC or anything like that. But if you give them, you know, external iliac as well, doctors would be happy, like, all right, this is really extensive. This goes high up, you know. Again, external iliac coming from that top corner, diving down. So we know we're in that external iliac. So it's showing a, you know, obvious large acute, you know, DVT. Got absence of color flow. Vessel looks enlarged, dilated. We can see those intraluminal echoes, hypoechoic. So here we can see nice respiratory variation on one side and the other side looking a little more monophasic. So we've lost some of that phasicity now. So this looks relatively flat compared to the other side. So this is right side, this is left side external iliac. We can see the obvious differences between the two waveforms. So in this case, when we see those differences between the two waveforms, the one that is continuous, that we don't have those phasicity, that respiratory variation, we then worry about are two things. It's either internal obstruction, a clot inside the vessel higher up, or external compression, something inside the body that's compressing that vessel from the outside. So then now it's up to us to try to figure out why we have those differences in waveforms. So in this case, it was a large pedunculated uterine fibroid that was actually compressing the vessel in this patient. So it was a large uterine leiomyoma or fibroid that was compressing the vessel on the right side. IVC thrombus. So third vascular class, we're going to be getting into, you know, IVC imaging and looking for that IVC thrombus specifically. But it is something that we can potentially, you know, diagnose and see on ultrasound. So here we can see our inferior vena cava coursing posterior to the liver, nice sagittal view. Now transverse view of that same IVC now. You can see the thrombus within the vessel itself. So if there is IVC thrombus, you know, this can cause a flattening of those waveforms. So a loss of that phasicity. loss of those respiratory variations. EMS, have you guys done liver, a little bit of liver yet? No, not yet.
Just the common wild dog.
Just CBD, but like in lecture, have you guys talked about that? Okay. I would say this looks like a cirrhotic liver, it's all the societies going on, it's
I
not
saw
your
that.
cirrhotic liver. So pro position, so really, it's all about compression when we're doing these leg Dopplers, starting at that common femoral, compressing that femoral vein all the way through. So you're just gonna stop it, you're gonna compress as you go at different intervals, so you're sliding that leg, compress, 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 working your way all the way down towards that knee. So you don't have to be so thorough where you're barely moving, you can slide, compress, slide, compress, slide, compress, slide, compress. So you don't have to really go slow and work your way down the legs. Cause you're also looking at screen, you can kind of appreciate when there's intraluminal echoes. I don't know. I see a lot of people, they'll start especially when you're so focused on your screen. You're compressing, you're compressing, you're compressing, you're going. You think you're at distal leg and then you'll turn back and look. I'm like, all right, take a look at the patient. You're like way up here still. You think you've gone that whole leg already. So this is showing what the vessels would look like, as we're going common femoral through down towards the femoral vein, working our way distal. So common femoral, initially, when you're higher up, you'll just have the artery and the vein. Coming down a little bit further, you see that saphenofemoral junction. And then as you come down a little bit further, then we have this split into a femoral vein and the deep femoral vein. So this is going to be in lab, one of the first pictures that we get in that area. We're going to try and turn on this, try and see the two vessels as they split. Continue to work your way further down, you'll get further separation. And then eventually you're not going to see the deep femoral vein anymore. And you're just going to be focused on that just the femoral vein around mid thigh, and you're going to continue compressing it down towards distal thigh. And it runs a little bit deeper as you get further down. Some of you, it's going to be a little challenging to visualize that distal femoral vein, depending on your body habitus and how deep it is, because it does run in the abductor canal once you get further down. So it gets a little harder to visualize. This is just kind of another diagram showing, the proximal thigh vessels. This is now the left leg. You can see the veins medial to the artery. And then how it just kind of splits. So again, you start with just common femoral vein, common femoral artery, coming down a little further, you get that saphenofemoral junction. Common femoral vein still hasn't split yet, but we're past that junction, the GSV is on its own up there. Then working our way down, we have our split, and then they're slowly migrating further away from each other. So then you can kind of just appreciate how it looks with the actual portion of the vessels, at each corresponding segment. Those of you that are a little bit more, visual. So again, most important thing is that we compress the vessels completely, make sure that vein compresses completely down. So right lower extremity showing common femoral artery, common femoral vein with and without compression. And recognizing right leg, left leg. Now the vein is medial, so we know that this is the right leg. Arteries are out lateral. So you just have to just take a moment, kind of just visualize, all right, my notch is here. That means I'm on the right leg, if I've seen the artery on that side. Common femoral vein, nice spectral Doppler with augmentation. So for me, I personally would just lower my Doppler scale a little bit, make that waveform a little bit larger, but again, we could still appreciate the phasicity to it, the respiratory variation, and you can see the nice augmentation to it as well. Our famous Mickey Mouse, common femoral vein at that saphenofemoral junction. We know that this is the right leg because those veins are medial, the arteries are lateral. So here we can see a thrombosed now vessel, so with and without compression. So particularly with compression, you can appreciate, the spongy, clot, the intraluminal echoes with compression, it's not compressible. These are more free floating thrombuses now. So again, with these, they still have kind of smooth borders to it. Even though these look a lot brighter, a lot more echogenic, these would still be considered acute thrombuses. Particularly these because they're not affixed to the wall, they're not really adhered to the wall, completely. So with these, again, free floating thrombuses, or these mobile thrombuses, we worry about a high propensity for, hello? Yeah. All right. All right, fine. You guys are gonna have that perk too, like everyone in my wife's church, whenever they get an ultrasound, they send a report to me. Like, what does this mean? This guy was in a motor vehicle accident, and he got an ultrasound, and they said they saw something on his spleen. And I was like, and shit, they were worried it could be cancer. I'm like, well, that's pretty rare. I'm like, was he passenger or was he, it's probably from the motor vehicle accident. His spleen's vascular. I'd be worried about ruptured spleen, a hematoma on the spleen, something like that, it's probably not cancer. So I was asking her, I was like, was he driving or was he passenger? And they're like, well, the doctor said it didn't have anything to do with the accident. I was like, probably did, but well, the young guy, so I'm gonna take a look later at the report, but betting it's like a hemangioma or something, or hematoma, or hematoma. So again, when we do see thrombus, we then want to avoid augmentation. So this is not just showing a split screen with and without compression, normal or abnormal, obviously abnormal. So these veins should compress completely. So again, this is just an acute DVT within the vein now, common femoral vein. And we know that this is the right leg, again, because the vein is medial to that artery. The veins are medial in towards the groin. You guys can hear this voice over and over. Arteries are out lateral. And you'll get a feel too, when we're in the lab appreciating and scanning, if you see the artery, just tilt inward towards the groin and the vein comes right in. Here we see another artery and vein, common femoral artery, common femoral vein. Yep, left leg, exactly. You can see intraluminal echoes, these spongy intraluminal echoes within it. Vein looks dilated. Even looks like we got some phlebitis going on, so that vessel wall looks like it's probably thickened as well. A little harder to see, but looks like there's some vessel wall thickening. I'm sorry? Yeah, this is definitely acute, yep. Yeah, when you see like a big honking clot in it, it's acute. Really, for chronic, I look for just those thin linear echogenic straining, like almost like webs within the vessel itself. Anything that's other than that, I would just call acute or just call it a DVT. No lab's going to fault you for that. Even if you just say it's a DVT and not really specify acute or chronic, once the radiologist starts looking at it, let them make that call. Yeah. Who is it? Was it you were with IO? So Tiana was in the vascular lab and she was following the tech, and since they were the first persons to see that clot, even though it looked a little more chronic, we were the first ones to image it. You still have to call it as a DVT, as an acute DVT, because you really don't know when it formed or when it happened. But if you're the first one to document it, and there's no previous history on that patient, you still have to call it positive for DVT, even if it looks acute. And let the doctors. No, you just say acute, positive for DVT, yeah. Which is good, important because you guys as vascular techs, or if you are doing vascular, you actually have the ability to start the whole chain of command or chain of process, like where they start medication. So when you do find a DVT, it's our responsibility to then contact whoever's taking care of that patient and just notify them like, hey, I just did this study on this patient, they're positive for DVT. And you can tell them, what segments are involved if you wanted to, or just let them know they're positive for DVT. And then to, check for the preliminary report. And then at that point, they could start the whole process of getting that patient started on anticoagulation. So there's no like lapse in patient care. So you guys do like with critical findings as a vascular tech, you're responsible for contacting the providers, before that report actually gets dictated and read. So there is a lot of responsibility on you in that aspect of it. A lot of times from when I was first starting to do vascular, when we would actually chart in the patient's charts, we would put all our preliminary reports in the patient's charts, like positive, negative values and stuff like that, critical findings. And then we would call and then document who we spoke to relay those positive results to. And usually like they would start whatever treatment or intervention that they needed right away. So it's a little bit different than general ultrasound. General ultrasound, you really don't have that, like that aspect of it. So this was just showing now slow flow mimicking that DVT. So this is a patient, that's got slow stagnant flow. Looks like we see some intraluminal echoes within it. When we put our color on, we're having a hard time filling it with color. But when we compress down, it compresses all the way down. I'm like, all right, what's going on here? Like, I didn't see any color at first. It compressed completely. But if we do a little augment, we're actually able to fill that vessel with color. So this is just a patient that's got slow stagnant flow. So again, any condition or any situation where we have this slow flow, again, this is that nice environment for developing those blood clots, that DVT. So it's a nice prime environment. So then we might have to figure out why does this patient have this slow flow, particularly, this high up in the common femoral. So maybe there's, again, something compressing that vessel from the outside, or maybe there's something inside the DVT higher up that's causing this. So that saphenofemoral junction now. Hard to see over here. So common femoral, the saphenofemoral junction. This one's a lot easier to see now on this side. So I'm going to have you guys practicing just getting this image in transverse. It's a lot easier to visualize the junction in transverse. So typically you'll do also a split screen compression picture at this level, showing the common femoral and that saphenofemoral junction compressing down. And then you would just do a color or a Doppler of that junction as well. You'll see some more normal saphenofemoral junction images. The right junction with complete compression, left junction with complete compression. Again, your goal is just make sure that, again, everything compresses down completely. You're left with just the arteries. So with GSV thrombosis, so again, great saphenous vein is a superficial vein. So if there is thrombosis within that GSV, it's not technically considered a DVT. It would be superficial thrombophlebitis. But if you're in this junction and you notice that the GSV is thrombosed, but it's not quite getting into or extending into that common femoral vein, you then should take a measurement to try and measure how far away from that junction that clot is. So for us, we use this 1 centimeter threshold. So if the clot was less than 1 centimeter away from that junction, then that's kind of concerning. And we potentially worry about little pieces of this breaking off, embolizing, or we actually worry about this, eventually soon being able to propagate or extend into that common femoral vein. And then at that point, you have a DVT. Also, if it's very close to the junction, they might elect to anticoagulate that patient. Because again, typically they don't anticoagulate patients. They don't put them on those on heparin or something like that if it's just in that superficial veins. And so sometimes it's a little hard to just measure it on 2D. This was a nice 2D image where you could see that delineation. But I would also put my color box on and you can see the color would go right up to that clot. And then you can kind of get a good measurement, as to how far away it is from that junction. This is now another picture now. If this might show up for you guys on the test. The GSV and the common femoral vein. So we can see now clot in the GSV and it extends into the actual common femoral vein. So this would be considered a DVT because it's now extending into that common femoral vein. And this patient does need to be treated with anticoagulation. Thrombosed saphenous vein with extension into common femoral vein. So partially occlusive thrombus. So in this instance, now we can see that the patient's great saphenous vein is patent. There's still blood flow getting through. So when we put our color on, we can see that saphenofemoral junction filling the color, and then we still get some flow around the periphery of that thrombus in the common femoral vein. So this area is thrombosed. We're still getting some flow around it. So this is considered partially occlusive because there still is some flow getting through. But this is still, an acute DVT. Here we can see some partially occlusive, but again, another partially occlusive thrombus in that bifurcation into the femoral vein and deep femoral vein. So we can definitely see some filling defects. There's thrombus within the femoral vein. There's obvious thrombus within that deep femoral vein, but still some areas where there's some blood flow getting through. And these are all still acute clots, acute thrombuses. So color bleeding pitfalls. So color bleeding is going to happen when your color gain is set too high. So you just want to be cognizant and careful of that. If your color gain is too high, you can actually cover up and mask a clot that's within a vessel. So in this case, the patient had a partially occlusive thrombus, but since the sonographer's color gain was set too high, we were actually obscuring that thrombus. So you could see it, in sagittal, you could see it in transverse, in two planes like that. It's in the same location in both planes along that posterior wall of that vessel. So you just want to be careful, not setting your color gain too high and basically hiding or masking these DVTs. Lymph nodes. So particularly when we're in the groin, we're able to visualize the inguinal lymph nodes. So we have a chain of lymph nodes in your groin. So don't mistake it, for a thrombosed vein. You guys will learn to recognize, lymph nodes fairly readily. They're going to be very superficial. They're going to be anterior to the vessels. The vessels will always be deeper, where these lymph nodes are very close to the surface. Again, if you encounter enlarged lymph nodes, you don't have to go crazy measuring all of them. I've measure the largest one you see, maybe measure the largest two. So you do, transverse, you turn on into sagittal, your two measurements, your length and your width, and then put color on it, see if it's hypervascular as well. And then, just call it a day. Incidental finding, enlarged inguinal lymph nodes noted in right lower extremity or left lower extremity. This is mislabeled. No, wait, that's lesser saphenous. So it's GSV. So now we're just seeing that again, common femoral GSV junction, and then that bifurcation into the deep and superficial femoral veins. So in the lab, I'm gonna have you guys try and get this image here where we have common femoral vein splitting into your femoral vein and then the deep femoral vein. I'm gonna have you guys, a lot of labs will have you then Doppler each of these. Depending on your lab, you might have to do a split screen compression at this level, showing compression of both of these vessels as well. This is one of the images that we're gonna try and get in the lab, just that bifurcation of the common femoral and the femoral and deep femoral. More pictures showing that femoral bifurcation. But again, depending on your lab, they might require you to do a split screen compression image at this level for the proximal femoral vein as well as the deep in one image. So you are trying to acquire something like that where you can see differentiation between the two femoral veins. And then you just do a split screen compression, ensuring that both of these compress down as well. So again, depending on your lab, that might be a required image for you. But again, most labs will have you do a Doppler at this level, just to document basicity, and augmentation at that level. For your normal femoral vein flow. So again, nice basic respiratory variations. Again, nice optimized waveform. Again, lower your Doppler gain to make that waveform larger so you can appreciate those respiratory variations very easily. So this was just going from common femoral to femoral vein transverse grayscale with and without compressions. So normal femoral vein, as you're working your way down the thigh, that femoral vein is typically posterior to the artery. So we see the artery above and the vein posterior to it as we're doing our compressions through the thigh. So again, vein posterior to that artery, so with and without compression. Just keep in mind that some people, like we said, about a quarter of the population can have a duplicated femoral vein. So typically the main femoral vein is, again, directly posterior, and then that duplicated one can sometimes be off to the side. Sometimes could be anterior to it, lateral to it. So just keep an eye out for any duplication of that femoral vein. Particularly if a patient's had a previous DVT, they might wind up with collateral vessels as well. So any collateral vessels that you encounter, you also have to make sure those compress as well. So the abductor segment. So now this is the distal femoral vein, so just above the knee. The vessel runs through what's called the abductor canal. And it's much, much deeper, so you can see how much layer of tissue we have to scan through. So it's layers of muscle tissue, tendons and ligaments. So sometimes the vessel becomes kind of difficult to visualize when we're in this abductor canal segment. So I'll teach you guys how to kind of change your approach, come a little more anterior and angle back at it. Also, when we're in this abductor canal segment, we typically have to compress the vessel by pushing from the opposite side of the leg to try and compress the vessel. So we'll use that technique using the other hand to compress from behind. So A and B was with the probe a more medial approach, so it was a little harder to see when we were more medial. So again, you can see all the layers of tissue, muscle that we're running through that abductor canal. The vessels were much harder to visualize, but then by coming more anterior on the leg, we're able to visualize the vessels a little bit easier. We'll practice that in the lab. And then this is the distal thigh compression technique by using your other hand and applying pressure from the opposite side of the leg to try and compress the vessel rather than trying to jam down and compress the vessel. Again, like I said, if a patient has a duplicated femoral vein, just ensure that, both vessels compress. So in this case, we had one compressed, the other was thrombosed. So just, again, be cognizant, that all the vessels compress if they are duplicated. So this was an isolated deep femoral vein thrombosis at the origin. So in this case, here's the femoral vein. This is the profunda, the deep femoral vein. You see some interluminal echoes within it. So again, with chronic DVT, this is what I'm looking for. It's that thin linear echogenic strand within it. That's a good representation of a chronic DVT when you see that chronic venous scarring. So from the abductor canal, we then work our way inferior and we get into the popliteal vein. Again, popliteal vein now is behind the knee. So we have to take that posterior approach. So since we're coming now posterior, the vein is going to appear like it's anterior to the vessel. But again, just keep in mind that the vein is still posterior to the artery. It's just opposite or appears opposite because we're taking a posterior approach. So when we're doing popliteal vein, you really have to get into that popliteal fossa. So you really get in there behind the knee. You're compressing up and down the popliteal vein. Again, ensuring there's no thrombus. You're going to do your split screen compression, showing with and without compression. Turn in sagittal, elongate the vein, get a nice color picture, nice Doppler picture. So in addition to the popliteal vein, when you're doing your DVT study, you're also going to want to assess the gastrocnemius veins, as well as the small saphenous vein while you're back here. So we're going to work on trying to get an image where you see the popliteal vein as well as with the gastrocs. But again, a good sonographer, while they're imaging the popliteal vein and checking for clot within that, your eyes are also, taking a look at that the gastrocnemius vessels, as well as the small saphenous vein. So we'll see if we can differentiate, the two. When you compress, your two veins will compress down, you're left with just the artery. So the gastrocnemius veins are paired, two veins with one artery. And then the small saphenous vein will just be that vein by itself. You won't see any corresponding artery with it because it is, again, a superficial vein. As you work further down that popliteal fossa more inferiorly, again, these will start to separate, move further apart from each other. And then you'll typically see the gastrocnemius vessels off to the side, small saphenous vein off to the side, the opposite side, more superficial. But again, just keep in mind, if you do see thrombus within the gastrocnemius vessels, that is considered a DVT because there is a corresponding artery and those are deep veins. So gastrocnemius vein is, thrombosis of that would be considered a DVT. Whereas with the small saphenous vein, it would not. That would just be the superficial thrombophlebitis. So the popliteal vein and the small saphenous can also be interrogated or imaged with the patient in a prone position. So if you had to, you can try and turn the patient over and prone them to try and image to get into that popliteal fossa. Again, if they're not able to externally rotate their hip out. I could show you guys a more lateral window that I kind of taught myself and learned, particularly in patients that are elderly or they're contracted where their legs are completely straight and they can't bend their knee. You get these little old ladies that really can't even bend, or if they're in like a really contracted position, particularly if they're been in the ICU. You can kind of come from lateral from the side and still get a nice image of a popliteal vein. The DVT in the popliteal vein, now we just see with and without compression. So obviously that popliteal vein is not compressible. We can see those intraluminal echoes within the vein itself. There we can see another popliteal vein now. So this looks like it's probably maybe a free floating thrombus. So this is, even though it's a little more echogenic, this still looks acute because it's got smoother borders to it. It's not those thin linear echogenic lines. Again, this would be an acute thrombus, probably a free floating thrombus because this is kind of just hanging out, free floating or moving around if we're in real time. Even though it's partially occlusive and free floating, it's still again considered acute. So here are the arrows just kind of pointing to the echogenic flat-like area that's adjacent to the wall. So this is some scarring due to some previous DVT. So this chronic DVT is a little bit harder to see. Let's see if I have a better one. Yeah, so any pictures that I give you guys, it's going to be obvious if it's acute or chronic. So this is a classic example now of a Baker cyst. So when we're back here in the popliteal fossa, something else that we could potentially encounter are these popliteal cysts or Baker cysts. So it's going to look like a large anechoic cystic mass. It's going to be a little bit medial to the popliteal fossa and anterior or above that gastrocnemius muscle. So in sagittal, you can see, you know, the extent of that Baker cyst. In transverse, sometimes it could take almost like this, like horseshoe shape appearance or like a comma shape, where it wraps around that head of that gastrocnemius muscle. Sometimes in transverse, for me, it's a little bit harder to get a transverse measurement, whether I'm measuring kind of like that or more like that. But in long, you can get a good measure length and then, you know, width or AP. With these Baker cysts, again, you want to put your color Doppler on, take measurements, determine the size of it. Then we also worry about the potential for these Baker cysts rupturing. So this is showing a panoramic view of the main Baker cyst, and then a rupture of it and a leaking of that fluids contacts into the proximal calf compartment above the gastrocnemius muscle. So if a patient does have a ruptured Baker cyst, their calf is going to swell up. It's going to be tender. So it's going to mimic the symptoms again of a DVT. So transducer approaches for calf veins. That's kind of confusing to look at. So in terms of transducer position, we're going to come medial. So we're going to come from the medial aspect of the thigh. We're going to put our notch right up against the tibia. And this is going to kind of be our window to try and visualize our posterior tibial, and then the peroneal is deeper. So here's that bone of the fibula. So here's tibula, fibula, and then we see the peroneal veins anterior to that fibula. So you guys will be able to appreciate that when we get into ultrasound. So when we were doing the arterial duplex, we were using some of these landmarks to try and find the vessels as well. It's the same window as when we were doing the arteries. We're just going to try and locate the veins now.
What does that mean by the transducer position there?
Like the red arrow at the bottom.
Yeah.
I think this is coming to the photo of the transducer over here. Very misleading.
It is very misleading. It looks like it's saying come posterior. Yeah.
Right, well,
But
that's
it's,
what
but
I
it's
was
not
wondering.
You're coming from.
Oh,
medial.
well, no, but the whole side is called posterior transducer position. But then the transducer is medial.
It's medial.
Should it be? Thanks for nothing.
Um. Yeah, she kind of jumps back and forth here. That's cool.
So it's just kind of the picture, yeah.
Yeah. So this is now just, I think I have more for transducer positions, like,
Can I ask one more question? on
sure,
that?
sure.
So if your transducer was positioned in that way, the image that we're seeing, that's how it would appear on the screen.
Like this?
Yeah.
Yes,
Okay,
yeah, so what we're seeing on the screen,
so medial would be to the,
let's say,
you know what I mean?
yeah. I want to see if I have a nice picture just showing like the bone. Yeah, so this is kind of like with that medial approach. So this is like what we're seeing. So here's the fibula, the bone, the shadowing with your transducer notch kind of right up against it. Here was that, I'm sorry, tibia, fibula, then peroneal veins, posterior tibial veins. So this is kind of that, this is that medial approach, what it looks like. So then transducers come in medial, so our transducer was medial. And then we came into the posterior tibial and peroneal. Here was that other bone, the fibula, tibia is over here. So this is that other one, is this guy.
Yeah.
So that's what we're seeing. So before I was mentioning, visualizing the gastrocnemius vessels as well as the small saphenous when we're doing the popliteal. So again, in that popliteal segment, with the gastrocs, you can see multiple sets of gastrocs. So here we have one set, here's another little set of gastrocs, gastrocnemius veins. So again, you want to make sure everything compresses because you could potentially have just a small isolated thrombus in one of these four veins. So again, just be careful that everything compresses down. Then you can see the small saphenous by itself, with no artery with it. Those gastrocs kind of look, again, like little dumbbells almost. They look like the cat veins. They're paired. This one's a little bit harder to see. Again, you have your popliteal artery, popliteal vein, small saphenous, again, off to the side by itself, superficial. And then your gastrocs, gastrocnemius veins with the artery in the middle. So when you're imaging the right lower extremity, I can show you guys when we get in lab. Some places might actually have you image the tibial peroneal trunk from the popliteal. So it's just a simple matter of angling inferior towards the top of the calf. And you'll see the popliteal vein split into two vessels. That's when you know you're at that tibial peroneal trunk. In terms of, getting into tibial peroneal trunk just prior to that, it's really going to be one artery and two veins, what you're imaging. Working your way further down into the calf now, so you're going to kind of jump out of that popliteal fossa, come into that proximal calf, to try and image the calf vessels once you get into the calf. really the hardest thing about calf veins is just, you know, trying to visualize them. So you're gonna scan, trying to find a nice little window to visualize them. And then just, yeah, you're just compressing up and down, so. Don't be so fixated on trying to get both in the same picture, it's okay to just have dedicated image for posterior tibial. And then dedicated images for the peroneal vessels. Some labs will have you do both in the same image, so posterior tibial, peroneal. Where you're focused on, you know, prox, mid, distal calf. At Christiana Vascular, they actually do a clip. So they do a sitting clip where they hit clip store and they just compress through the calf, showing compression for the posterior tibial and peroneal veins. I'm not sure if Union does that as well. I don't know if you guys, anyone's been at Union.
I was like,
They didn't do a clip,
They didn't.
they didn't do calf veins.
Yeah, the only thing I saw was a carotid.
Okay,
I saw it, but they didn't do it.
they didn't do clips.
When I was at the hospital, only one of the techs did it.
The clip for the calf veins.
Yeah. But she had so much plaque,
Oh.
like, it was bad. And one of the techs does a clip of every single vein from the whole body. He doesn't do any still story.
Is
It's
that
Dan.
Mike or Dan?
He doesn't do any still story, like, he doesn't do any of that. He does everything as a clip story.
I mean,
Okay.
I only see clips for women doing like different organs, like superior and inferior. You just do a full sweep of it.
Even his like compression shots are not like the dual things, like he just does a video of him compressing it.
Okay,
I feel like that would be like.
faster or better.
Yeah.
More accurate.
Yeah,
he
I
does
feel like
it-
why don't we just
I
do
mean,
that?
yeah, he does an entire venous study in like 5 minutes, so I'm not gonna tell him he's wrong.
I
but-
know. You got it. And
Some of the vessels was like, he's like, I'm not even gonna waste my time doing this in transfers. He's like, I can compress it.
To be honest, that's probably the direction it might be going in terms of ultrasound, like having all these, I guess,
There's a-
the imaging capabilities, like, I mean, back in the day, ultrasound, you know. It used to almost be still images, like you, like, before everything was like digital and electronic, and you had to like actually submit. Like thermal image papers of your studies, like when I first started doing vascular, we had to print out, like, we had to take pictures and then cut the pictures out and. Make a little folder and send it to the doctor, like with the images, so they would go through your images, okay. So now everything's digital stored now, so the storage capacity, like. When we used to take clips, the doctors would go nuts because like it was so hard because it was every frame, so it was like, you know, watching a movie, they had to scroll through every frame. So they would like have to take their little mouse and just kind of go like this and scroll through all your frames. But now they can play it as an actual, you know, video. So when their viewers, like when you store clips, they can see it as the movie as you're doing it, as you're storing it. But storing a clip takes up a lot of data space. So like, I can't even imagine like all the data space that a hospital has to like, you know, have on their servers and everything to store all this stuff or in the cloud somewhere, like.
Yeah, I didn't see anyone else do any clips at all, it was just him.
That's all right,
He was doing them for every patient.
for every patient.
At Union, there's like a protocol where it's on the side and it just labels exactly what you have to do.
Nice.
Like she did it in like 10 minutes. Yeah, the computers in the vascular lab, they have, you open what kind of exam you're doing and it puts the protocol on the left side. And then like, as you take each image, you click which, like, it moves automatically through them, but you can skip around and then it like automatically labels them and stuff. Yeah. But I was confused because the texts were not taking most of the pictures in the protocol. Like, they would skip like over half of them and then just be like, if we're done. And so I didn't know, like, are you supposed to do all?
Supposed to,
Okay.
should. I would,
Okay, they were just like, a lot of the boxes wouldn't be checked and then they would just end the exam.
yeah, a little bit of advice, you'll see things done and you'll question it, and be like, well, they didn't do this or they didn't do that. You do what they tell you to do, you do the full protocol, even if you see them skipping stuff, you do the full protocol, because then they'll be like, oh, she missed the image, she didn't do this, she didn't do that, like, you know.
Yeah, that's fine.
They'll kind of like trap you like that, be like, that's how you just did it, and like,
Yeah, well, cause one of the texts was telling me, he was like, one of your second year students, like, she just tries to do too much, like, she just overthinks it and she does way too much. I was like, well, you just didn't do the entire program. Like, I feel like she's probably just doing the program.
She do too much.
And then I was like, oh my god, I'm never comping with this guy.
So posterior tibial arteries and veins. Again, these calf veins are paired. The posterior tibial are gonna be more superficial, closer to the surface with that medial approach. Peroneal veins are gonna be a little bit deeper. So here we can see nice, posterior tibial and then the peroneals deeper. Again, peroneals are gonna be just anterior to that, fibula. When we turn in sagittal or elongate those vessels, again, we should see a nice presentation with vein, artery, vein. There was a nice, patient where we were able to image, all the vessels, all 4 vessels. Again, if you're able to image or visualize posterior tibial and peroneal in one image, one shot, you don't have to worry about necessarily taking dedicated images of each, you just label it, right, posterior tibial and peroneal veins, prox cap, mid cap, distal cap, or just proximate distal, depending on which level of the cap you're imaging. And then just show with and without compression.
Should you label
Like
that
that,
you're compressing? 'Cause I feel like we didn't do that in the screen.
like this,
Uh,
like with, like,
Well, so in the last picture. They have it labeled. Yeah, that one.
like artery, vein and all that stuff,
No, like on the,
With compression.
with compression.
with compression.
Like, should we be labeling that?
A lot of the machines, when it's taking you through the protocol, it'll have the labels, it'll pop up as a split screen. And it'll have, with compression, without compression. You can, I mean, it's good practice to like just label over here with compression.
There's a button, like, at least on this machine, I'll put on here, there's a button that you can click that says like with compression.
Oh,
with compression.
I feel like I haven't.
But all the things that say at the clinical sites, they label on that.
It automatically pops up usually.
Oh.
Like as you go, if you put in a protocol like the Phillips, there's a lower extremity DVT protocol, so you guys can
I haven't
select.
seen that.
Like the one we have here, like you could select it, and I believe as you're going through it, it pops up like with your labels and it, I think switches automatically as you're going through, it'll pop up with a split screen. So with peroneal veins, sometimes it might be a little difficult to image all the peroneal vein or image both in one segment. So if you had to take more dedicated images for just the peroneal veins, again, just slide a little more posterior and sometimes you get a better window for those peroneal veins. So we can practice that. Nice, pretty calf vein pictures. I wish we were all this clear. So if you guys can again identify your calf muscles. So A are your posterior tibial, B are your peroneals. So C is your tibia, D is your fibula. Fibula, yeah. So with calf vein DVT, I remember starting out and just being like, oh gosh, I'm not gonna be able to find these calf vein DVTs. Thankfully, when the patient is positive for DVT and these calf vein vessels, they're much more visible. So it's much easier to see the vessels. They become much larger, much more dilated. It helps you to try and find that artery. So if you can locate the artery, because the artery typically is never going to be thrombosed or clotted unless they've got, really bad peripheral arterial disease, but that's a whole nother issue. But if you can find that artery, then you can your eyes can then hone in on where the veins are. Particularly in sagittal, you can put your color on and you could then visualize those veins, they don't fill with color, they're thrombosed, they're clotted. So if there is DVT within the calf veins, you then have to image in sagittal as well. So they'll require you, you do your split screen compression, you just demonstrate that they're not compressible. And then you would turn in sagittal to see if, if they're occlusive, partially occlusive, see what's going on. So you then would acquire a sagittal image of the veins, demonstrating, absence of color. You'd also typically do a pulse wave just to show, that there's no flow within the vessel as well. So in this case, just one of the posterior tibial veins was thrombosed. So this can definitely happen. Where one is patent, you're getting blood flow through that anterior one, but that posterior vein or that posterior tibial vein is thrombosed and clotted. So again, just keep that in mind. So one of the two pairs, can potentially be thrombosed. Doesn't necessarily have to be both of them. So this was taking a more posterolateral approach to try and image peroneal veins. So that's another window that you could potentially utilize to try and image the peroneal veins if it becomes difficult to visualize from that medial window. So our anterior tibial veins. So this is when we were imaging the anterior tibial artery. Again, we came along the lateral aspect of the anterior portion of the leg to try and image that ATA, but now we're just going to try and see if we can find the veins for our comp. Anterior tibial veins, again, are not something that are typically imaged during a normal lower extremity duplex study. Again, isolated thrombus in these vessels are very, very rare. So again, it's not something that we typically would image. But again, it's a good idea to just be able to know where you're going. So, when you do get out into clinical setting and you're practicing, it's not something that's completely foreign to you. You know where this vessel lies, you know where you're looking. So that anterolateral probe position, you can also potentially visualize the peroneal veins as well. They would just be deeper on the other side of that muscular fascia compartment. There's your anterior tibial vessels. Anterior tibial veins at that popliteal junction. So this is very proximal. So here again, you can see posterior tibial, your peroneals a little bit deeper. Depending on how skinny that patient is, how thin their cap is, you can also potentially pick up the ATAs as well, or I'm sorry, ATVs, anterior tibial veins. So the soleal veins. So soleal veins aren't going to come in until we get around mid calf. So they're going to be medial to those posterior tibial and peroneal vessels. So medial or a little more posterior. So I can show you guys how you can kind of swing around, see if you can visualize the soleal veins. Again, not every person you're going to see soleal veins. Typically, you won't visualize them unless they actually are thrombosed. But you can have, again, isolated soleal vein thrombosis, because we said, again, this is the most common vein to become thrombosed. So this is oftentimes where a lot of these cap vein DVTs originate and then propagate into the posterior tibial and peroneal veins. So in our lab in New York, when we had a neuro ICU, we had a lot of stroke patients that were, bed bound, intubated in the ICU for long periods of time. We found a lot of soleal vein DVTs, a lot of isolated cap vein DVTs. So again, when you suction the soleal vein, do your split screen with and without compression, and then turn it sagittal, get a nice sagittal view of that vessel as well. That's thrombosed. Put your color, your pulse wave Doppler. So here we can see in transverse, looks like a vein, that's you know, it looks like an occluded vessel. It's not compressible, we don't see any flow within it. But then when we turn in transverse, the structure looks, you see these, you know, series of linear striations within it. So this is more likely either a nerve or a tendon rather than a vein. Again, if you see a structure like that, particularly when you turn in sagittal on it, you know, and it has that appearance where you see your multiple linear striations within it, it's more likely a nerve or a tendon. You know, you can follow that up and down. So then turn back in transverse, follow it up and down, see if it connects back to another vessel. Because again, veins will all connect into each other, so all roads lead to Home. So if it is a vessel or is a vein, it's going to connect into something else, or it's going to branch into something else. Where if it's a nerve or tendon, it'll just kind of continue by itself, and then you'll either eventually lose it or disappear into a muscular compartment, so it won't go anywhere, it won't connect back with anything else. So in terms of GSV, again, also depending on whatever clinical site you're at in your lab, the great saphenous vein might also be included as part of your lower extremity duplex exam. So I know at Christiana Vascular, their code for their lower extremity venous study is like lower extremity veins groin to ankle, so it doesn't even like specify. So they do images for great saphenous vein as well. They didn't do GSV.
I didn't see a single one.
They,
And they had,
they did. They made me do it when I was working. Like
the only
when
time I
was
saw
working with
them do
students
it
there.
was we did a vein map of the
Vein map.
GSV because they were gonna use it.
Maybe they changed it. I hope.
Well, I think, well, like I said, the half protocol got left empty, so it was probably on there.
Probably on there.
Cause they actually, they let me like do this on a patient, like they had me like back scan and like run through the lower extremity venous. And that wasn't one that I did either. Like they didn't do it and then they didn't have me do it.
So for us in New York, like our protocol when we had to do a lower extremity duplex is we just imaged the GSV by the junction. And this was just dedicated for vein mappings, like she said, when we were focused on those superficial veins. When I came here to Delaware and I was like working with students in the lab and I pulled up their lower extremity venous protocol, it included the GSV as well, and we had to image, you know, through the thigh. So we had to do the junction, then we had to do prox thigh, mid thigh, distal thigh. Then we had to do in the calf as well, 2 of the GSV in the calf as well, so a prox calf and a distal calf. We had to do split screen compressions, and then we had to do 1 Doppler in the thigh and 1 color and Doppler in the calf as well. So it was a kind of, I thought it was like, wow, that's a lot for like a lower extremity duplex to rule out DVT to do all that extra imaging. But in terms of the GSV, it's going to be located more medial along that thigh. So your deep veins kind of run probably about here. In order to get that GSV, you really have to come along that inside of the thigh, that inner thigh, to image the GSV. So it's going to have a similar appearance to your cephalic vein, where it kind of almost looks like that eye of Cleopatra. You see it coursing within that compartment. Once you get into the below the knee, into the calf, it's going to be very anterior. Again, coursing along that shin, it's going to be very superficial. There again, so now you can see that GSV, so it's kind of in this compartment where it almost takes that eye appearance. It's going to be very superficial. You might see little branches coming off, so you might see some smaller superficial varicosities kind of above it and the tissue layers above it. Just keep in mind, particularly if these patients have varicose veins, you might see some dilated superficial varicosities, and then the actual main GSV a little bit deeper. So long saphenous vein or great saphenous vein, again, coursing down the leg. Small saphenous vein, this one is going to be that also referred to as the stocking seam vein. So this one's going to run directly along the posterior aspect of the calf. So again, it just runs right along the medial, the mid portion of the back of the calf. So you can track it up and down the back of the calf, and it connects to the popliteal. There you can see closer to the popliteal fossa, the small saphenous vein by itself, then those fascial borders. And then you're working your way down the calf. The gastrocnemius vein versus small saphenous vein. The gastrocnemius is deep vein, it's accompanied by arteries, or it has an artery with it. It's embedded within the gastrocnemius muscle, so you should actually see it within the muscular compartment itself, in the actual muscle. Small saphenous, again, superficial vein, there's no associated artery. It's gonna be typically more superficial, a little more posterior. So this is now calf veins kind of working your way now distally down by the ankle back up towards the popliteal, so kind of just going in reverse. So from the medial malleolus, from that inner ankle, just kind of working your way upwards. So down by the ankle, you can see the posterior tibial veins. You're working your way up. Eventually, the peroneal veins will come into view. Keep working your way up, working your way up. They're getting closer together, and eventually they're going to join, form that tibial peroneal trunk. And then tibial peroneal trunk eventually becomes, just the popliteal vein. So this is just working your way up in reverse. So this was just showing a lower extremity venous exam that stops at the popliteal vein. So this was just showing compression, common femoral vein coming from artery that was compressed. So now working your way inferior a little bit, you have your saphenofemoral junction. So here you would also do, a split screen compression. Then working your way down a little bit further. Now we've gone past that junction, you see the GSV all by itself, still common femoral vein, hasn't bifurcated yet. Working your way down a little bit further, now that common femoral vein is split into superficial femoral vein and deep femoral vein. And then we get coming down a little further separation of those vessels. And now we're primarily at this point just focused on that femoral vein and femoral artery, and we're following this down the thigh. So, prox thigh, mid thigh, working your way down to the distal thigh. Yeah, so this was showing transverse, a duplicated femoral vein, and then getting behind the knee popliteal. Then once you get into the calf veins, after imaging popliteal, you move into your calf veins. Try and get some, images of the posterior tibial, peroneal, prox calf, mid calf, distal calf, depending on your lab's protocol. So really doing a lower extremity DVT study is really not that difficult. It's just, becoming familiar with the vessels, recognizing the vessels, understanding, what you're looking at. And then just ensuring that everything compresses. In terms of interpretation, for you guys writing your preliminary report, so normally, the veins should be easily compressible. They should have thin walls. They should be able to collapse easily and completely. So you should be able to compress it down wall to wall. If you're doing a reflex study and you're assessing the valves should be competent. There should be unidirectional flow. blood flow going in one direction. We should demonstrate, particularly in the more proximal segments, basic respiratory variations. Most important one is no color filling defects. So when we get our nice color picture, again, we want that color, that vessel to fill wall to wall with color. We don't want to demonstrate any sort of filling defects, because that will look like, we're showing a clot or a DVT. We're gonna want to demonstrate our augmentation with distal compression. Again, if it's a reflux study, there should be absence of reflux in a normal study. For interpretation for our preliminary report, we would demonstrate, we document if the vessel demonstrates incomplete compression. We can document the presence of intraluminal echoes. So, say for instance, it's positive for DVT and, the common femoral vein, you would say, right common femoral vein is either partially compressible or non-compressible with intraluminal echoes visualized. There's absent color flow or absent color filling or partial color filling, if it's partially occlusive. In terms of the waveforms, you could say, loss of, respiratory variation noticed or continuous flow noted within whichever segments, or absence of augmentation demonstrated in this particular segment. So these are all kinds of things that you potentially could put in your preliminary report. You could document also the thickening of any vessel walls. If it's a reflux study, you can document, which valves are functioning or non-functioning. Again, if it's a reflux study, you might focus also on those perforators and presence of any reflux in the perforators. You can also document any superficial varicosities or superficial varicose veins. So if you have a patient that has a lot of varicose veins, I would typically just compress over those varicose veins to make sure they're not thrombosed or clotted. And you can just do an incidental finding, like superficial varicosities on medial proximal right calf or something like that, wherever the location of it is. And you can do a split screen with and without compression, showing that the varicosities are patent, they're compressible, there's no clot within those superficial varicosities. So clinical guidelines, patients who are suspected of having suffered a pulmonary embolism and have unilateral swelling. This is, definitely recommended that they get a venous duplex exam. Patients who have suspected of suffering a pulmonary embolism and that don't have any leg swelling, they might go directly for that VQ scan or a CTA for the lungs, CTA angiogram to visualize the lungs to determine the presence of pulmonary embolism. Patients who have, they're suffering from pulmonary embolism symptoms and they have a negative duplex, this must be followed up by some sort of exam to assess the lungs as well for the presence of pulmonary embolism. We said that VQ imaging was that nuclear medicine procedure, the ventilation quotient imaging. So that one's not as specific as a CT angio. So that CT pulmonary angiography is much more specific and much more diagnostic in terms of diagnosing pulmonary embolism. So that's really your gold standard when you want to rule out pulmonary embolism, is doing that CTA. Scanning difficulties. So we've all encountered a lot of these difficulties with doing a low extremity duplex. So the patient's very obese. They might have a very large pannus that hangs down over their groin. So you really have to kind of lift up their stomachs, get in there, get into the groin, to image your common femoral vein. So don't feel bad about asking the patient to potentially hold up their stomach if you had to, like, you gotta get the pictures you gotta get.
Feels wrong.
Yeah.
Feels wrong, but you know what? Some patients, they know, they understand, like, oh, I got this for you, and like, they don't even, you don't even have to ask them. They're like, "All right, I got it."
I need that, cause otherwise I feel so bad, I don't want them to think I'm being like rude about it, or that just feels like a silly sentence to say.
So,
Just lift every.
Yeah.
I mean, if you don't want to ask them to do it, you know, you could just, you can hold up with one hand and try and image, but then you gotta like, you know, just hit freeze and then city loop back to get the pictures that you need, you know, I mean, it's just, it's an extra step. but- Yeah, it's not, it's not.
Yeah, I was just saying that I'm doing it awkward.
Those times you want the gloves that go up to here, you know.
Oh.
You're digging, but yeah.
Right.
Patients that have excessive swelling can also make it very difficult and challenging. The little caveat to that, if it's truly just edema, like water or fluid within the tissue, water is a nice acoustic medium to let your ultrasound beam go through. So if it's just very edematous with edema, sometimes it actually makes the imaging a little bit better, to be honest. Because you have just all that fluid now that that ultrasound beam is going through. Dressings, casts, so if a patient has dressings on their legs and they have wounds, ulcers, and there's dressings, you can ask if you could potentially remove any dressings, so call the doctor or physician if they're inpatient that's covering that person. If they're in a cast, can we remove this cast to be able to image what we need to? If not, image above or below those segments that are obscured. So you can then, you know, kind of get a good idea, particularly with your Doppler. So you can pulse wave above the area, below the area. So if the waveforms look pretty similar and you have augmentation, you know, you demonstrate augmentation, you demonstrate basicity above and below it, you know, then that's a pretty good indication that there's probably not a clot underneath there. I mean, essentially you can't tell because you can't image there, and you can't do compression, but you know, get images above and below any limited areas. So again, limited areas, again, require images above and below. So again, if you could show respiratory phasicity, it's probably patent. These are examples of some of the worksheets that you might write up, you know, for some of these DBT studies. So again, it shows your different segments, right and left. So sometimes they would have you just check off like, you know, compressibility, phasicity, and then augmentation. So you check off yes, no, you know, like, was it phasic? Was it compressible?
That's what they usually do on their computers.
On the computers, yeah.
I haven't seen a paper yet.
Yeah, now it's everything's going digital, like these actual worksheets that you fill out, everything seems to be digital now.
Really?
You wanna see paperwork?
The digital ones, like most of the time what I've seen is they all just like click to autofill with normal results, and then they go through and change the categories that weren't normal, so they don't have to put in a lot of it.
Yeah.
It takes them like 5 minutes. Yeah, it takes them like 5 minutes to finish the report.
There's another ultrasound worksheet. So again, you have your different segments, you know, was it visualized? Yes or no? Was it compressible? Yes or no? Put in any comments, you know, spontaneous flow, basic flow, did it demonstrate augmentation? So yes, no, yes, no. It's kind of like, you know, what I grew up on. Like these things, but yeah, everything, like you said, it's digital now, and then like auto populates to a normal, and then kind of changing your different things.
Even the things that they change, it's just like a drop down list and you select
it's a
the rate
drop-down
that it was
And
in.
it gives you, yeah, like
Like,
they
they don't
don't
really
have
have to
very
type
phrases
anything.
for echo, like.
They
They
have
have
to
no,
know that the software for that is just expensive, so they just haven't switched over yet, so.
They're Christiana, right?
Divorce?
So why would they switch it for all the other?
Yeah, all the Christiana sites.
Well, I will say it wasn't vascular, so.
Oh,
Yeah, even
And they are
the
definitely
labs.
different entities, like they don't even talk, we even call them. We will call us for vascular need, and we just were like, call vascular, they don't even do the number. I was like. We don't do that.
You don't do that. So superficial varicosities. So these are varicose veins, these are large, these are big. So not every patient is gonna be very large, so these are very over exaggerated. So in the course of doing a lower extremity duplex, you can potentially come across people that have superficial varicosities or these varicose veins. They're gonna be superficial, very close to the surface. They're gonna look very tortuous, very twisty. As you scan up and down, you might see these veins that kind of do these loops and circles and kind of come in and out. So it's really hard to kind of like, open this, elongate. It's gonna look like a series of transverse, sagittal, kind of all jumbled together. When you see varicosities, the most important thing is to just demonstrate that they're patent and they're compressible. So I would get a nice split through wherever I see some varicosities, I focus in where maybe it's most severe, or maybe take a couple of levels wherever they have these varicose veins. So I would say like, right medial calf prox, right medial calf distal, mid distal, left lateral calf, proximate distal, or wherever they are in the extremity. Annotate. So here you see left upper inner calf. I would say maybe proximate distal, wherever it is. So again, patients that have superficial varicosities, they can tend to be quite painful, particularly if they're very large and dilated. But again, you're going to want to demonstrate, a split screen with and without compression to show that they compress. And then I would do a nice color picture. So I just kind of stay in my transverse orientation, try and fill them with color, showing that they fill completely with color, and then you can call it a day. But if they are thrombosed, then you want to document, the presence of thrombosed superficial varicosities. So that's the medical term. That's how we call it, superficial varicosities. So I would say, like patients right, inner calf at mid segment demonstrates superficial varicosities that appear patent and compressible. So if they're patent and compressible, that's good. Or if they're thrombosed, like thrombosed superficial varicosities noted in right, mid calf, right mid medial calf.
So when you said that their classes are gonna be, or kind of be painful for them, and more so like it's not gonna be painful to be pressing on them, they're just gonna be experiencing
Pain, tenderness, yeah, they'll have like calf pain and tender, yeah, definitely understand. You're putting extra venous pressure. But yeah, I have this pain, they're aching, they hurt, like, so that's kind of the thing like vascular surgeons go off of, like if you have varicose veins and if it's a cosmetic thing, do they bother you? Do they hurt? And if they don't hurt and you can deal with it, and just kind of deal with it, but
when you're compressing them, are they gonna like,
feel pain.
are they gonna like go through the roof?
Depends on the patient. It really depends on the patient. I mean, I've had patients like, like I'm barely even, ma'am, I'm not even touching you with the probe and you're screaming, like, please, like, oh, it hurts. I'm like, yeah, we're not even touching you yet. Like, this isn't gonna go well.
One of the texts told me, she said that you just kind of have to like, kind of not really ignore them, but like take it with a grain of salt. Cause this one girl, she was like,
Although curse you
screaming.
sometimes.
Yeah, she was like in pain, and then she's going to like we went to the room to get the transvaginal probe, and she's like, you kind of get used to it. Like I've done this before, and it just gets annoying because then you go to stand them, you see nothing. Like it's likely just like gas pain or something, and it's just like they just kind of put on a show. So I guess some patients are more dramatic than others.
Yeah.
Which makes sense. Yeah.
Well, if you see something like this, like you could see obvious, thrombosis within it. You can see the clot within it. You can put your color on it. If there's no flow, then it's thrombosis. You don't necessarily have to push that hard. Like particularly if it's completely thrombosed, you put a little pressure, just like, yeah, all right, it's obviously not compressible. But they're also very close to the surface of the skin, so you're not pushing very hard, very deep, so you don't necessarily have to put that much pressure on it. But yeah, I mean, yeah, some patients are champs, they handle it, they can handle the compression. Other patients, you're barely touching them and they're screaming at you. Like, stop now, I can't.
I'm so afraid of upsetting the people that I would just sit there and like die before I said anything.
Well, if you explain to them, beforehand, like I'm gonna be going down your legs, taking compression and
No,
pushing,
I mean like if I was
compressing
the
the veins.
patient, like I could be in the worst pain and I would be too scared to say anything.
I'm telling you, like I have to push down on the veins, so I have to make sure that they compress all the way down. That's how we
Yeah.
can prove that there's no clot within them, so this is what I'm gonna be doing.
Yeah.
We kind of prepare them before rather than just go into the groin and start jamming away, Give them a little heads up.
What were you saying?
I was doing a kidney and the guy jumped like 5 feet. And I was like, I'm so sorry, because there was no tenderness, like when the tech did it.
Was it just
I
a
was like,
shell?
I'm so sorry, like, was that, like, did I hit a painful spot? And he was like, no, but you tickled me. I was like, oh, you screamed like, I'm really sorry I tickled you.
Here,
No?
what you got here? What's it there? Is this next week's test? I don't like that it says midterm.
You don't like it says midterm? Well, we don't have a midterm anymore.
Oh, so it says next week's test.
Yeah. Label your vessels. Our handy dandy pictures. Right, label your arms, label your legs, all your main routes.
I couldn't see it. I couldn't see the whole screen.
Did see the whole thing.
Now I get it. I need all the help I can get. It really just.
Yeah, it's just veins. Yeah, it's all just veins. So this is high up now. So we got our IVC. So first branch of that IVC,
Really, yeah?
which one?
External, internal,
Common. Common, yes, common.
and then that's.
So common then splits into internal and external. So the external, we had a little inguinal ligament there kind of drawn in. Then coming down the leg, now it's common femoral. Common femoral splits. So that's the deep femoral. And then main root is your femoral.
You know, watch me still get them.
I probably.
Laterals are anterior.
Yeah, most lateral anterior
Anterior,
tibial. Anterior tibial. Now in the arms. Basilic's a deep.
No, the superficial.
Oh, was it? All right. I thought you guys.
Gosh.
Go in reverse, 12. Oh, very good, yep.
I just think
That's
it's
Basilic, yeah.
as a unit.
Well,
Let's
well,
take
well,
the
you
test
can
and
take
see
the
what
lead.
it says for yourself.
There you go, yeah, we're the only thing in the.
Is this the way it's
front.
like? Yeah, your picture's fan.
And then.
I know that they're.
There's some
Flash
action there.
Yeah.
And then for his there was something.
Minus IGB.
What is it?
Yeah, internal jugular.
Alright, let's see those multiple choice.
I know. No, I'm like, oh, wait.
Right,
Oh, from-
yeah, it's a big old thrombosis, yes, acute
Oh.
thrombosis. Where's my questions?
And last time we were talking about it, you said like understand like the vertical triad, it's like primary versus secondary varicose veins.
Yep.
Sir, Isabella, Dula, and the other one.
Phlegmassa cerulodolens,
Yeah.
Phlegmassa abodolens.
Then you said recognize the lymph node,
For pathology, yes, yeah.
and then understand continuous pulsatility and basicity waveforms.
Yeah.
Wait, all these questions are on there? Is that all?
You can I bet you guys can answer pretty much all of these questions.
Wait, these are actually on there?
These are actually on
No,
there.
like, I'm genuine.
Some of them we haven't covered yet, like we
I know, I
did, we
saw
haven't done
some,
Gracilis
like,
immuno.
Is this the real test?
Yes,
These are the types of questions that we're gonna be asking, yes.
I guarantee.
But the ones that we don't know yet.
Scientific veins are best visualized with the patient with condition.
We haven't done this, but
Reverse
what do you
still
think?
work.
What?
Well, yeah, well, we don't have reverse developer, but
Good lumbar.
what's gonna create the most,
And there's
I guess, hydrostatic pressure, or what's gonna, when a patient is standing, exactly. So standing, we do reflux studies with, patients standing, so it's called a standing reflux, but we haven't done that yet, that's good, that's coming. Or how about 40? There you go.
Wait,
So
So
with
that's
that,
the-
without cyanosis.
that's the don'ts. No.
Yeah.
The ones is worse than the.
No,
the Corella ones, yeah, I did that.
Yeah, so the Cerulodolens is with cyanosis. So this one is pallor, so it's without redness or without cyanosis is. That's how.
So
So
that's really,
alvedolens,
that's really the only word that we've been talking about.
yeah.
That's what I did.
Cellulitis will cause redness.
So what was the answer?
It was
Hey,
the first one out of the.
Yeah.
What?
Everything I do, I'm saying like all the time.
Like the Doppler, all that, what did you say you were gonna? Yeah.
What do you think, Ed?
I guess not.
On track 46?
Does not feel you gotta change your color. You gotta decrease it.
So if it's not filling, you definitely want to increase your color. gauge.
Yeah, increase it.
So I
Increase.
cross off that one.
What's color filter?
Color filter, so that's your wall filter.
I think
So,
it would be A for the answer. If there was a change. I would have just asked, because I would have said increase. Is PBR the scale?
yes,
PRF
PRF is scale.
Yeah, so I think you would decrease the
Decrease your
scale.
scale,
Then
increase
increase,
your
yeah,
gauge.
yeah. That's what I would do.
Now you're
So
down to
PRF
one of those
is scale.
two.
That'd be A.
Then what's color?
I don't know.
Color filter, so, the machine has something called a wall filter.
Is that on it?
Yeah, so wall filters,
Speak for yourself. Yeah.
so you have high wall filters and then you have low wall filters. High wall filters will filter out high velocities. I'm sorry, high filters allow high velocities to pass through and they filter out low velocities. So with venous studies, you actually want to lower your filter. You want to decrease your color filter, so having a low pass filter. So low filters will filter out, it's kind of counterintuitive. I always add the word pass into it. So when I talk about color filters, I say high pass wall filter or low pass wall filter. And then I know what velocities pass through that filter, and that's what I'm seeing. So a low pass wall filter, a low wall filter allows low velocities to pass through the filter and allows me to see them better. And it filters out all the other stuff. High wall filter or high pass wall filter allows high velocities to pass through and filters out the other stuff. So I add that word pass into it. High pass wall filter or low pass wall filter. So in this case, we want a low pass wall filter. So we're gonna decrease our wall filter, decrease the scale or PRF, and then increase color gain. Yeah.
Easy, guys.
I was laughing the other day because I remember he goes,
When I ruined it.
when you ruined this fun game for us. I hate you.
It's okay, I know.
The
it's progress.
exam should go up.
Honest.
It's obviously a cognitive program.
Yeah, you're like,
Oh, wait, yeah. Like 30 minutes. That's a lot. I love her.
I would go.
What question are we on?
It's medium.
What are we?
Wait, sorry, what question are we
No,
on?
it wasn't the practice, I was not there,
It was
was
a 7.
No,
The grades were comprised of
Yeah.
here a little, right?
What?
Well, then it's also a lot of, think
I
about
choose
where it
E.
is in the body, I don't know.
You should have give up.
Yes, I would.
You
Give up.
yeah,
I would
just
check
give
to
up.
see if they had a graph, but they just don't have it.
I have
Decrease
so
the
good.
pressure. Well, that's.
Yeah.
Cause you might be,
You might be compressing it, yeah. You're probably compressing it.
That was easier.
Yes, if you don't see it, you're probably compressing it.
I just know every time I couldn't find a vein, Dan was like, "Well, are you pushing?" I always
I'll
was.
just-
Well, I was like, I'm not touching, but I'm still.
Well,
Yeah, if the GSP is running here, you're not coming lateral, you're not.
It's also,
coming-
it's so superficial, I feel like it probably collapses so easy.
Yeah. The GSP is just gonna always run in that, it's never gonna run anywhere else, like.
It's not identified, I
Do you
assumed
guys-
like it was not identified properly.
Oh, the next one has to be.
Yeah.
Reverse from Dellenberg, patient position for duplex lower extremity. Reverse from Dellenberg. Easy.
Not easy. We're all answering these tiny business the hundreds right now.
I mean, you guys are answering these for me, I'm not saying.
Yeah, we have three much projects there.
Oh my god, I forgot posters.
Yeah. but that's-
Oh, yeah, no problem, great exams, one poster.
Difference between gastrocnemius vein and small esophagus vein are true accepts. Let's see, I love these accept ones.
Well, they
Gastro-
got-
I think this is gastroenterologist and a small esophagus.
It is fair.
Yeah, it is. I think it's,
Wait, see if that's
Yeah.
true.
D.
oh wait, I'm thinking true, never mind, D.
Oh, wait.
A is true.
Oh. Oh wait, D's true.
They're all true. The none of the above.
E.
The above. Where is it?
They're all true.
Never go from true, but. Yeah.
Yeah, pulmonary embolism, definitely.
Longest vein is the small side. No,
Right,
really,
right,
it's not
exactly.
happening.
Which question? Here, or 22, 23, you just did 24.
Normal vein diameter would blank and Doppler signal would blank if the patient performed all solid maneuver.
And the Doppler signal would. Cease. Decrease, wait.
Decrease.
No.
What's cease mean?
Stop.
Stop.
Oh,
I think we're missing D. Where's D?
normal veins
Yeah.
would.
Where's D? Where's, is it up on this page?
That's going to say.
And the Doppler, oh yeah.
Yeah, there we go. I'm like, we're missing some choices there. There's no other right.
The trick question, there is no answer.
Wait, go
I was
back
just
to the
looking for
question.
C's.
Normal
The
vein
vein
diameter
diameter.
increase?
Yes, diameter would increase and the Doppler waveform would either cease or decrease. Let's see.
Increase.
So if you put D, so D.
Oh, never mind, I'm.
But you said D short or decrease.
Just say it.
So it could be a word.
Judging me.
Should go away, should cease.
I didn't know.
I wouldn't necessarily deduct points if you said decrease, but should be cease. That's the most correct. These conditions are normally dilated tortuous veins of superficial venous system. There are two types. So primary, secondary, varicose veins.
Well, that was the.
And
Yeah, because primary are, let's see, primary and secondary benefits. Because primary is actually really associated with that primary.
Oh, yes.
Wait.
Yeah, I was looking at it. It's the hardest certification you get for like his job, and I was like, I don't know. Only like 10% of people pass it. And I was like, yeah, she gets him nice. Page 27, for 26, yeah, for me, it was like, yeah. And I was like, whatever, like, this guy I have to press about, like, I think I realized and then I was like, well, I don't know, I'm like, I don't want to explain to you who it is. We're not doing this stuff, I was like, this will be- I'm 17. I don't know.
27 is B.
Like, I don't, wait, 27 is big? Dude, what is it?
That's the most common
Common
site.
site. Where does it say that?
I got one.
Good job, Queen.
Wait, where is it?
27.
I didn't read the rest of the question, I just got the first part, but I bet it happening. Most common please for. Oh, yeah, we just talked. Colonial.
Guys can answer these questions.
I love.
Every year for my birthday, I request that instead of a cake.
Oh my god, it's such a surprising. Whoa. I should say, I do have a story.
So like the characteristics of the Venus ulcers,
Characteristics of the salsa?
yeah, so
No. They are.
honey discoloration, you have,
You
I
need to
don't
read the
think they call
question
Chinese-
number.
42.
no, you're right, that's arterial, so shiny skin's arterial.
Yeah, so that B is incorrect.
Yeah, so they have irregular borders, they're very shallow. Might have presence of varicosities. So that location near that medial malleolus, that's referred to as the gator zone.
Oh, yeah, when they have that. Sometimes with your name. Oh, no.
Applying for further. Oh, I just took.
Posterior tibial.
It'll be E. Where's the Hunterian one? Isn't that closer up to the top?
I know, we're on 43 right
That's
Or just going back on.
Oh,
You know what?
So those are also referred to as the dot,
The cocket.
cocket, sorry.
That's what I was looking for. I was looking for those names. No.
Posterior tibial periphery is also the cocket.
What?
No, yeah. Augmentation. It's B.
43.
Yeah, so an
Me,
increase.
it's like, they don't even.
Yeah, so after Valsalva, like when you release Valsalva, you get a slight augmentation of flow, so you get a slow increase in flow.
Yeah.
So for that one, you're looking for A.
Yes, for 44, yeah. What does this look like? Very pulsatile. So if you see very pulsatile flow. Yeah, it's a heart issue, congestive heart failure.
So you need to add up the. What is 57? That's the place where it's working for us. You better reach out.
Yeah.
Collapse means to compress that, yeah. When a vessel collapses, it compresses, yeah.
Wait, what's the time? That's the different.
What did it be? Oh, they had it going on.
Collapse means compress.
That hurts.
What? Depends on location.
Oh,
Which one's most?
wait, which one would be, was it Steve?
I think it's B
Or-
because the.
Is it?
Yeah,
Yeah.
when it goes to the adductor canal, you gotta reach behind and squish them.
Right, no?
It's like, which one?
Which one is it, Dan?
It's like behind.
Option six,
Yeah,
seven, I think
Yeah.
is B.
What's the fee?
Yeah.
Hold on.
Wait, what was the answer for
One
57?
57.
Oh,
B.
I don't know.
What?
57 is B.
No, abductor canal, yes.
Yes.
Yep.
In a sending contest.
Where would you guys look for a baker, sis?
Behind the knee.
Yeah.
top-
Top
top
seal
of
fossa.
tail.
It's 53.
Symptoms of pulmonary embolism.
Where's the next?
Oh.
All the following except. Well. Very good. What? Hi. Yeah, I hear you now. Yeah, I'm gonna work out. Yeah, we're just reviewing for this next week. With students here, but it's fine. Okay, all right, sounds good. Okay.
Popular today.
Every day.
I was just about to say, that phone's always ringing. It's a nice soothing guitar moment.
No wonder we.
Wait, so what was 54? I thought it was collocation, that's not pulmonary embolism, they wouldn't
Okay,
have
that's what I
collocation,
thought.
would they?
What in between the dots and crest?
No, you tell me,
Definitely.
would they have claudication?
No, right? Yeah, no,
No. What is claudication?
the cramping.
Yeah, yeah, exactly.
Well,
Well, right.
and then it carries, well, the pulmonary. Sorry, what if they have more? Yeah.
Yeah, so pulmonary embolism, the big ones, tachycardia, your heart's racing fast. Shortness of breath, those are your big ones. You're short of breath, you can't breathe. Feel like you just like walked up a flight of stairs. You're tachypneic, you're breathing fast. These patients can also spit out blood, so hemopoiesis, they can be coughing up blood. Chest pain, definitely. So if you have chest pain, all of a sudden, oh God, I'm short of breath, chest pain. You feel like you're having a heart attack, you're potentially, answer questions.
Said no trick questions.
I don't think so.
Damn.
Dan, just get the little basket with the numbers in it, shake them up again.
Yeah.
Let's
Shake
get
it
our
up again.
partners.
Let's get some partners.
Get
We'll be
Sophia, we knocked it out of the
I
park.
wanted to ask.
Yeah, we can
She's
take it
my
right
good
now.
luck
Charm.
Take it right now.